Yes, I think that the individualising the HRT is very, very important, not only in terms of dose at initiation, but also in terms of what hormones you're actually going to use, particularly, I think, for the progestogens rather than the estrogen. So estradiol 17 beta and conjugated equine estrogens have been shown to have many beneficial effects. But to some extent, certainly with the Women's Health Initiative trial, I feel that the outcomes were compromised to some extent by their use of medroxyprogesterone acetate, which metabolically is certainly not a good progestogen to use, and in terms of vascular effects is also not a good progestogen. Now, over in Europe, we have a large range of different progestogens to use. Medroxyprogesterone acetate is not used that much in Europe, and we tend to favour either micronized oral progesterone or the very similar dydrogesterone, which metabolically are very, very friendly progestogens, and also there is evidence that they have good vascular effects, or they don't have any bad vascular effects, and also evidence that they may well not have any influence on any risk of breast cancer, which may not be true for certain other progestogens. Yes, when you're considering starting on HRT, the important thing to consider is the age of the patient who's going to start on the HRT, and according to that, the dose that you're going to initiate them on. That is, to my mind, the most crucially important part of starting HRT, because there can be no doubt that if you get the dose wrong, if it's too high, you will increase the risk of venous thromboembolism, you will probably increase the risk of stroke, you may well lose any possible benefit to coronary disease. So it's vital that you get the right dose, and the older the patient is, the lower the dose needs to be, and you need to consider in individuals whether you would be better off with an oral preparation or a transdermal preparation. So by tailoring HRT, you should be able to maximize the benefits and to minimize the risks. Now, certainly in my practice, and I think in most European practices, we tend to initiate HRT fairly soon after the menopause, because the major indication is relief of menopausal symptoms. We do get women who are older that sometimes need HRT. Very, very rarely, you might even get a woman in her 70s who develops hot flushes for the first time, or they recur. Very, very unusual, and it's not common practice to give HRT to that sort of age group. But if you have to, and we're talking tiny numbers here, again, the dose is absolutely crucial. You would need to start on a tiny, tiny, tiny dose in order to prevent any potential harm, and there's a real risk of harm in that sort of age group. All of the major societies involved in menopause treatment, and that would be the International Menopause Society, the European Menopause and Andropause Society, the various national menopause societies, and the American Endocrine Society, were all in agreement that there should be no limit to duration of treatment. So you continue to treat for as long as it is necessary to achieve the goals that you were treating in the first place. One study did suggest that tapering down the dose of HRT was no better than stopping it directly. My personal feeling from clinical practice is that that is not the case, and I always do reduce the dose gradually. Again, monitoring them in terms of their symptoms. So we reduce the dose, wait 2 or 3 months, say, how do you feel? If they say I'm fine, then I'll reduce the dose again, and if it's low enough, stop it. But if they say, oh, well, I was okay, but no, on this very low dose, I don't feel as good, then I would go back to the dose where they felt good, and again, wait for a while, and then see if we can do it again. There's only been one huge clinical trial done, and that is the Women's Health Initiative. And although we've had criticisms of the interpretation of the trial data, certainly the trial itself was conducted in a very exemplary way, and we've learnt a lot from it. We have learnt so much from it that is good, as well as some that is perhaps not so good. But I think that the main thing is that we've got a variety of HRTs that we can use, and we need to tailor the HRT to the individual. And I'm quite convinced that that is best practice for HRT management. The main take-home message is mixed because you can interpret the debate in different ways. But I hope the main take-home message that people will go away with is that when they have got a good reason to use HRT, if they give it appropriately, it is safe. And so people shouldn't be afraid of giving HRT, giving it correctly, and they should not be worrying patients and taking them off HRT unnecessarily.
I think the main difference is I'm an epidemiologist and he's a clinician. And so I tend to look at the data. I don't treat individual patients. And so I feel like my presentation was very data driven, not that his wasn't, but I think when we talk about whether other formulations or lower doses would be in fact protective or beneficial, we just don't have the data. So I don't feel comfortable supporting that. So I think we agree that hormone therapy is very good for women who are having very severe hot flashes. So I think for those women, it's warranted. But I interpreted the debate question as to whether hormone therapy prevents chronic disease. So it's beneficial in really, because that was what the purpose of the WHI was. We didn't enroll symptomatic women. All these observational studies suggested that hormone therapy prevents cardiovascular disease, has a lower mortality. I mean, we thought, let's put it in the water. This is, all women should be on this. And so I think most importantly is that the WHI showed that there is a difference between doing a clinical trial versus observational studies, and it really pointed out the biases of the observational studies. And so I really think the risk of stroke is real. I think the risk of dementia is real. And those are scary things. These are really scary things. I mean, your brain, and there are other things. So if I don't believe it's cardioprotective, but if I look at the lipid changes, then I compare hormone therapy to statins. Well, if you're worried about coronary heart disease, give a statin because that works better than hormone therapy. So I see a much more narrow use of hormone therapy. I really see it only for symptoms. I don't see it for the prevention or treatment of osteoporosis. I don't see it for, I see a very narrow use for it. It's a very good drug for vasomotor symptoms, and they'll get some bone protection while they're on it, but beyond that, I don't recommend its use.
Were you surprised by the findings of the study as they evolved over the years?
I think we were all surprised. I was part of the HER study, which was the first. It was a heart estrogen progestin replacement study, and we targeted women with heart disease because the observational data suggested that you get more bang for your buck in women who have severe disease, and those are the older women. Those are the older women that. So the observational studies suggested that in older women with established disease, it's very beneficial. So I was part of the HER studies, and that's when the first increased risk was observed. And then in WHI, where the first 2 years, the DSMB monitoring, being on the steering committee, we heard, well, there's an increased risk of cardiovascular disease, and we thought, well, it's going to go away because that's what it did in HERS. But it really didn't. But I think the important thing is, I'm not saying WHI was a perfect study because Dr. Stevenson showed a slide where it showed that the risk initially of coronary heart disease was, in the initial report, statistically significant, but in the most recent report with complete follow-up and a complete adjudication that the p-value was not statistically significant. But the trial was stopped because of an increased risk of breast cancer and more risks than benefits. And I would agree there's problems with the global index, but we were trying to come up with some way to summarize the benefits of fracture versus the potential risk. And it's not perfect, but it's what we have. I think estrogen causes breast cancer. I mean, the observational studies, I mean, he criticized in one of his slides, criticized the observational studies, and, you know, there are limitations, but it's so consistent. I mean, and biologically, I mean, they've done like breast cancer cell line. If you give them estradiol, guess what? They grow breast cancer cells. Aromatase inhibitors, which is a slide I show, you lower estrogen levels to really low, guess what? You prevent breast cancer. So men don't get breast cancer like women do, you know? So I think, so in my mind, I don't understand the protective effect that was seen in the unopposed estrogen arm, but I don't believe that it's all the progestin. You know, a lot of people say, well, therefore it must be the progestin that's the bad guy. But I view it differently. But I will agree with Dr. Stevenson is that potentially other formulations may be quite much safer. We just don't have the data. And I don't know if we ever will, and that's the problem. Because I don't know if there'd ever be, I mean, WHI costs $800 million. There's never going to be another study like that with another formulation. But it is potential. For instance, transdermal estradiol, is effective for hot flashes, seems to protect bone, but it doesn't affect the liver, and so there's no lipoprotein effects. So what effect it would have on cardiovascular disease. So I think I agree that there may be safer formulations, but I don't think that we have the data. I think the pendulum is actually swinging towards Dr. Stevenson's viewpoint. And so I think, I mean, at least data in the US suggests that, you know, there was a plummet in the use, hormone therapy after the publication of the first WHI paper in 2002. But now hormone therapy is on the rise. And I hope it's on the rise because they're using it for vasomotor symptoms and they're not using it to prevent coronary heart disease, because I just don't think the data are supportive of that right now. You know, I was happy that Dr. Stevenson said it was a well-done study, and it really was. And and we picked the hormone therapy that was the most usual therapy that was used in U.S. women. Maybe it wasn't the right therapy, but we used the data that was existing in 1990. You know, and hindsight's always 20/20.
Of course.
And so, so I'm proud to be a part of WHI.
I'm Richard Eastle from the University of Sheffield, and I was previously a president of the European Calcified Tissue Society.
And I'm Bente Langdal. I'm a professor at the Department of Endocrinology in Aarhus, Denmark, and I'm the past president of ECTS.
So we're going to talk about the debate and how we thought the two challengers met the motion, which was really about the whole question of the benefits of HRT were greater than the risks. And it was being argued by John Stevenson, who I thought did a good job, because it's actually I thought it was a very challenging side to take, really. Because the evidence base is very much on the opposite direction.
Yeah.
The Women's Health Initiative study showing that there really are more harms than there are benefits for most patients who are given the conjugated equine estrogens along with the medroxyprogesterone acetate. That form of hormone replacement therapy just has more risks and benefits for just about all ages of women. And so he had a big battle to fight against the evidence.
Yeah, but I thought, I thought he did well, because what he tried to point out is that that's actually not the HRT form we are using, for instance, in Europe. So, but of course we have to be realistic about that the big study was done in the US, and therefore with the hormone replacement therapy they use there, as you mentioned, and that's where all the evidence is. So maybe I think he did quite well in trying to establish that there are little blips here and there suggesting that it might be different if you use the European formulations of HRT. The difficulty is just if there are data enough for us to actually take that on board.
Yeah, that was the key point. And one of the things that I was learning as I was listening to the debate was some of the risks that had been very striking in the early publications of the Women's Health Initiative were not quite so significant anymore. In the most recent publication of the Women's Health Initiative, then things like cardiovascular disease, the risk ratios weren't quite as high as they were in the initial publication. So that was helpful. And of course, we heard again about the reduction in all types of fractures that you get with hormone therapy, and the reductions in colon cancer as well. So there's definitely benefits that came out of the Women's Health Initiative for hormone therapy. It's just that the risks were outweighing. Although they did argue quite strongly, or John argued quite strongly, that the way in which the score was done may not be what every physician would choose, and that perhaps the balance of some things, some things were given too much weight and others weren't.
Yeah.
So the controversy was definitely still raging at the end of the debate.
Yeah, and maybe in the individual woman, if she is considering HRT treatment for menopausal symptoms, it's probably more worth to her to look at the individual things that were investigated, like heart disease, stroke, and other types, because she might be at higher risk for one of these than the other, and therefore it might have a more impact on her decision. So maybe it's not all about the overall score. I know that is what you do when you examine a big group, but it's really good to have all the individual information about the different events and potential harms, so that you might actually be able to give women better advice when it comes to considering using HRT.
Yeah. So I came away from the debate with just the sense that the forms of hormone replacement therapy that we use in Europe, they may well be better than those that have been used in the Women's Health Initiative. And what a pity it is that we've not seen the same large trials. Yeah. But of course, we may never see them now, because to get a funding agency to fund such research would be very costly, and you could argue it may even be unethical. So we probably will never know, and so I think, as you just said, that for the time being, much of the time we won't be using hormone therapy to prevent osteoporosis or treat osteoporosis, but certainly for the symptomatic forms, the hot flushes and the vaginal dryness and so forth, they do respond well, and that for the individual woman they may well be indicated.
Yeah, and if that is what she chooses to take for a while, then during this period she is very well protected against osteoporosis as well, and would probably not need another anti-osteoporotic treatment. So I agree with that, and I also agree with you that I don't think we'll see a big European study using European forms of hormone replacement therapy, and I think we need to be really realistic about all the things we don't know, and we cannot, just because we see some small studies with a little bit of sign in one direction or the other, we cannot conclude that this is what will happen if we started again using HRT in large scale in women without postmenopausal symptoms.
Yeah, great. Well, I think that's all of my thoughts about the debate. It was interesting how the swing went towards Jane Corley, so she did well to win. And usually the winner of the debate is from Europe, so she broke the habit. And we had an American winner this time.
She did. Yeah.